Next, we move on to carbon dioxide content. This test measures three components: carbonic acid, bicarbonate ions, and dissolved CO2 gas bound to hemoglobin. Most of what we measure reflects bicarbonate, which is regulated by the kidneys and the liver. Dissolved CO2 is regulated by the lungs. Therefore, CO2 content provides important insight into both the acid-base balance and electrolyte status. Normal CO2 values vary with age, and I have the values listed here. Children run slightly lower than adults, and newborns lower still. Critical values, anything less than 10 or greater than 40, since deviations outside this range can severely disrupt pH balance and cellular function. You're always going to interpret CO2 in conjunction with electrolytes and arterial blood gases. Clinically measuring CO2 content helps us to evaluate a patient's pH balance and metabolic status. Low bicarb suggests metabolic acidosis, as in diabetic ketoacidosis, renal failure, or severe diarrhea. Elevated bicarb suggests metabolic alkalosis, which can occur with vomiting or diuretic use. In practice, this test is often ordered alongside electrolytes as part of the CMP to give a more complete view of acid-base balance. When interpreting CO2 results, we need to consider potential interfering factors. Underfilling the tube can falsely lower bicarbonate levels, and certain medications can also interfere. Abnormal results should always be interpreted within the clinical context. This procedure does not require fasting, and a red top or serum separator tube or green top tube is appropriate. If we have increased CO2, we call that hypercapnia. This often reflects metabolic alkalosis or decreased ventilation. It can result from severe vomiting or gastric suction, which causes loss of stomach acid. It also is seen in conditions like COPD or hyperaldosteronism, as well as some diuretics. Patients with hypercapnia may present with confusion, lethargy, or respiratory failure if we don't correct the underlying problem. Hypocapnia, or decreased carbon dioxide, usually indicates metabolic acidosis. Causes include chronic diarrhea, renal failure, diabetic ketoacidosis, or shock. Starvation and chronic use of loop diuretics can lower bicarbonate. Clinically, patients may present with rapid breathing as the body attempts to blow off CO2 and to correct the acidosis. Recognizing this pattern is also critical in emergent care. When we come back, we will look at chloride.